over to you for strategies and application of compression sutures for rapid resolution of acute eye drops.
Yeah, thank you Purvasha and Jaya for the session. So I'll be talking on the strategies and application of compression sutures in management of large acute eye drops. As Purvasha and everyone has pointed out, the acute eye drops occurs due to a sudden split in the descemet's membrane and the Duas layer, leading to fluid accumulation within the stroma. It's gone into slide, yeah. So there are various management approaches, as we all know. The conservative medical management, all of these may have a role. The conservative medical management is favored in majority of the cases, and this is based upon the premise that there's a natural mechanism of endothelial cover which happens to seal the defect, and that is when resolution of the edema happens. Now, one problem with the conservative medical management in large eye drops is that it can have a delayed recovery, and over a period of time, as Suman also pointed out, it can lead to corneal vascularization, which might become a high risk factor for keratoplasty in future. Intracameral gas injection was a favored strategy for many years, and but the only problem is that when we have intracameral air, it can lead to raised intraocular pressure in an uncontrolled manner. It necessitates a PI to counter this, the effects of intracameral air tamponade, and this is based upon the premise of pushing the posterior membrane to the anterior stroma. So technically it is not a very ideal procedure as well, because the keratoconic corneas are biomechanically weaker corneas, and this is also ineffective for inferior breaks, and of course the other complications related to cataract formation, Ureus-Zavelier syndrome, pupillary block are the unwanted sequelae of having gas bubble in the anterior chamber. Full thickness compression sutures have also been a strategy, and this is done to bring the edges of the tear together, but difficulties of inherent to the procedure is there because one cannot pass the full thickness sutures through and through in a grossly edematous eye drops cornea. The sutures are also not designed in a way to pass the sutures through and through the area of the eye drops. So one of the modified technique which also works is to apply the sutures in a partial thickness manner, and partial thickness means that 50 to 60% of the edematous cornea. And with this technique, you'll be avoiding the use of C3F8 and SF6 gases in the anterior chamber with a minimal retention of air bubble at the end of surgery. And with the compression sutures, you can apply for various indications such as keratoconus, pellucid, and even other rarer cases such as trauma. And this is just to show one case where this was a patient who had a non-resolving eye drops of 3 weeks duration keratoconus, and the patient was developing vessels in the temporal part of the cornea. So this technique will involve making a side pour just as we normally do in other cases, and thereafter a gas bubble is injected. This is just air, atmospheric air, so it is filtered air, and to delineate the plane at which the posterior membrane is, and your sutures are all passed in a partial thickness manner from the periphery to the center. In this case, because we were not able to identify the location of the tear, the suture placement is from the periphery to the center, and thereafter in the center there's an infinity suture which is like an overlay and not passing through the stroma. So we can see intraoperatively itself there's certain degree of resolution of edema happens, and on day 1 we can see a remarkable resolution followed by recovery on the post-operative day 3 also. Now in this case, as the edema resolves in the peripheral sutures are redundant. These can be removed as early as 3 to 1 week time, whereas the central sutures are something which have to be removed later on, only when the healing of the posterior membrane defect happens, which is anywhere close to 4 to 6 weeks later. This is one more case of pellucid. I think Jaya will address this. I'm skipping this one. And this was another case of a thin cornea which presented with a 360 degrees breach in the posterior membrane. Was managed in a similar way by making a side port, thereafter an air bubble, and the sutures are again placed in the area where you see a relative translucency in the mid-peripheral region. The sutures are placed in this case radially because we are able to know the site of the defect, and this is perpendicular to the site of the tear. So following placement of the sutures, a BCL is applied. Yeah, it almost looks like a keratoplasty, but that's how it was. And this is a day 1 picture. And the 1 week picture where there's a good resolution of eye drops and edema in this particular instance. So there are some steps of the surgery which we need to understand. Why we are taking partial thickness sutures is because passing sutures through a grossly edematous hydrops cornea. When we pass partial thickness, it's way easier to apply these sutures. The sutures also act like conduits and drain the fluid like venting incisions. And thereafter, and because of this reason, we also see the edema resolving intraoperatively itself. We use air, 100% air bubble, not C3F8 or SF6, and this eliminates the risk of gas bubble complications such as pupillary block and other unwanted sequelae and effects. And this is not dependent upon the location of the tear. So it's not dependent upon where the gas is in the anterior chamber, and will have diverse applications. Now with respect to suturing patterns, there can be several patterns which we can apply in taking the sutures. General guiding principle is having the sutures placed perpendicular to the site of tear when it can be identified, when we are able to localize the tear. But when we are not able to localize it, as what is seen in the cartoon B, C, D and E, the placement of the sutures can be arcuate from the periphery to the mid-center, followed by an infinity or a vertical or a macro suture in the central visual axis. This is also because we don't want the sutures to pass within the stroma, and that will induce more scarring in the visual axis. So this could be the various modification configurations of applying the suturing in hydrops. And how do we localize? Quite often the localizing the break on anterior segment OCT is not possible because the cornea is grossly edematous, but intraoperatively using the light pipe or the endoablator is also something which can be used to localize the site of the tear. And how the mechanism of resolution of edema happens is explained by this cartoon, where when we apply compression sutures, the compression sutures effect is to bring the anterior surface closer to the posterior membrane, and thereby the natural process is facilitated. Now we did this technique in more than 29 eyes, but I'm just presenting this data where we looked at the resolution of edema with respect to the preoperative baseline edema. So all of these cases were grade 3 edema, meaning they were more than 5 to 6 millimeters in diameter, and the resolution of edema was quite dramatic, and 76% if we grade it to the preoperative baseline level on day 1, and subsequently 92 to 99% by 2-3 weeks later. Mean pachymetry, which was unrecordable at the baseline, became recordable on day 1 itself and was gradually reducing over period of time. Majority of the cases, yes, this will not prevent complete scarring. Majority of the cases could be managed with glasses and contact lenses. One patient did require a keratoplasty because he did not want to use contact lenses. So these are some of the representative cases as we see preoperative picture, and then on the same day how the picture looks like, and then on the day 4 the edema resolution, which happens dramatically on the next 1 week. And this is again one more case where we see a significant edema in the center, and there are multiple loculi, so there are multiple openings in the posterior membrane, and with a similar technique the patient has a good resolution. One more case. This particular case I just wanted to highlight. This was a patient who was a Down syndrome in 5 weeks history, and he was extremely photophobic. So this is a grossly edematous cornea, and this is almost like a long history, and some bit of fibrosis starts setting in because of the long-standing hydrop. So it's not an ideal situation, but because your sutures when you pass will keep on breaking because of fibrosis, you cannot have a real very compression effect. You'll have to take sutures multiple times. But then still, because the patient was very symptomatic and we had to manage this case, we took the patient, and with the same technique, it was from the periphery to center. The sutures were applied, and on table, like towards the conclusion of the surgery, the eye looks way better. And since we wanted to remove all the sutures, and day 1 also the peripheral edema clears, but since we have to remove all sutures in one go, not give multiple anesthesia to this patient, at 2 months when all sutures were removed, this patient had a decently fair corneal scarring and relatively better looking eye compared to how it would have healed otherwise in a long time. So this was something which can be even adopted for large eye drops with a long-standing history. Now this is one case which I would just want to share here, not that it has to be done in every case, but this was a patient who had again multiple loculi on the posterior membrane, and this can be made out from the profile view of the patient, and you can see that there's a relative translucence in the center. There are multiple loculi, and the cornea is grossly edematous, and if you look at the anterior part of the cornea on the OCT, there is a large area of defect there. Now in such cases, quite often when we pass sutures, a little tighter sutures, it can lead to cheese wiring of the epithelium. So this was one modified thing which was done in this case, where instead of taking sutures directly, and we can see that the center area, there's a big defect over there. So we used a BCL. The technique is similar, but just instead of just applying the sutures directly over the cornea, BCL was shaped into an 8 millimeter fashion, and this was placed in the central area, and sutures were passed over this. So instead of having the sutures pass without the contact lens, we placed it over the contact lens. This is just to avoid the cheese wiring which would have otherwise happened because the anterior part of the epithelium seemed very thinned out. So this sutures in a similar way are over the BCL. Now we can use many other things for this purpose. It could be a Bowman's membrane or anything else which could be used. Somashila sometimes suggested even amniotic membrane, but yes, Bowman's membrane I guess would be a good alternative. But in this case, this was one of the cases where BCL was applied to manage this case, and then subsequently on day 1, this was the picture, and this is the 1 week picture where we remove the sutures early in this patient. But this is the algorithm for management. Do we need to do compression sutures in all cases? It's not required for the grade 1 and grade 2 where the diameter is less than 5, where always is the conservative management which is preferred. But for something which is above grade 3 and more than 5-6 millimeters, this certainly helps in little faster resolution. Thank you.